Let's learn about ectopic pregnancy now. What is ectopic pregnancy? It is a pregnancy in which the fertilized ovum is implanted and is developing outside the normal uterine cavity. So the pregnancy is not at its normal location. It is growing at some other site where it should not be. What are the common sites for ectopic pregnancy? First common site is fallopian tube. Again, uterine but abnormal sites like the pregnancy can get implanted in the cervical region or at the angular region or at the cornu of the uterus, which even though the pregnancy is growing inside the uterus, but these are not the normal sites where the pregnancy should be growing. It can be ovarian or it can be abdominal. Primary abdominal means the implantation for the first time is in the abdominal cavity directly. That is primary abdominal pregnancy. Or it can be secondary. Either it is getting released from a tubal pregnancy and then getting intraperitoneally implanted. Then it is called as secondary abdominal pregnancy. Or it can be extraperitoneal, kind of the pregnancy getting released in the two flaps of broad ligament and growing there. So it is extraperitoneal secondary abdominal pregnancy. So these are the locations which are commonly seen in ectopic pregnancy. Fallopian tube, 97% of the times that is the site for ectopic pregnancy. So once we think of ectopic, the first thing comes to our mind is the pregnancy is not in the uterine cavity but somewhere in the fallopian tube. In the fallopian tube, the location is most commonly found in the ampullary region. Ampulla almost 55% time. Then it can be seen in the isthmic region of the fallopian tube. Then in the infundibulum, and the last part is interstitial. So you can remember this sequence as ampulla is in interstitium. So that's the thing you can help or you can use to remember that how frequently in the fallopian tube ectopic would be found at which particular region of the fallopian tube. So the most common is ampulla. And usually the abortion takes place at 8 to 12 weeks because you know the distensibility of that particular site of fallopian tube can accommodate only that much gestation of ectopic pregnancy. Once it starts going beyond that, then abortion takes place or tube ruptures. Isthmic portion is the narrowest portion, so the rupture occurs much earlier, 6 to 8 weeks. Infundibulum and then in the interstitium. Interstitial portion has a long space to distend, so longest survival of tubal pregnancy is found in the interstitial region of the fallopian tube. So almost till 12 to 16 weeks the ectopic pregnancy can grow there. So that's the longest survival. Again, I want to stress this point that ectopic pregnancy most common site at fallopian tube, and in the fallopian tube ampullary region is the most common. What is the etiology? Usually, when the fertilization takes place in the fallopian tube, the ciliary action of the fallopian tube muscle or the interstitial ciliary portion brings that embryo to the uterine cavity and there the implantation takes place. This is a normal phenomenon. Suppose there is any problem which avoids this, that means the factors preventing or delaying the migration of this fertilized ovum from the fallopian tube to the uterine cavity, these factors will cause implantation in the fallopian tube itself. They are avoiding this transfer to the uterine cavity. So the implantation takes place in the tube itself. Or there can be factors which will facilitate the nidation of the fertilized ovum in the tubal mucosa and thus the embryo remains over there. So any of these factors would lead to ectopic pregnancy. What are these? Most common is PID, pelvic inflammatory diseases. If a patient has history of PID, her risk of having an ectopic pregnancy increases 6 to 10 folds. Salpingitis may be post-sexually transmitted diseases like gonococci, chlamydia infection. Infection may be post-abortal or puerperal sepsis. So these infections, they damage these cilia which transfer this embryo from the fallopian tube to the uterine cavity, thus leading to ectopic pregnancy in next pregnancy. Causes of ectopic in PID. As I said, first common cause, loss of cilia and impairment of muscular peristalsis. Second, these infections can just have adhesions and thus they narrow the lumen of the tube and that embryo can't get transferred to the uterine cavity. Or there can be pocket formation due to adhesions between the mucosal fold and the embryo gets stuck in these pockets. There can be kinking or angulation, maybe because of intratubal or extratubal adhesions, which will again hamper this travel of the embryo. Use of contraceptives. We use contraceptives to give us protection against intrauterine pregnancies. So they may increase chances or implantation of the embryo extrauterine. Which are these? Kind of intrauterine devices, especially progesterone containing. Progestasert or progesterone only pills, they have progesterone. So they decrease the motility of the fallopian tube and thus they hamper the transfer of the embryo from the tubes to the uterine cavity. Even copper T, which is an intrauterine device, gives protection against intrauterine pregnancy but may lead to increased chances of ectopic pregnancy. Condoms and barrier methods, they give protection against both intrauterine as well as ectopic because they are not allowing the sperms to ascend up. Tubal surgeries, again a very common cause of ectopic. Either sterilization surgery or reconstructive surgery for previous tubal damage will lead to tubal ectopics. Intrapelvic adhesions. These adhesions, even though they don't affect inside ciliary action of the fallopian tubes, they lead to impaired motility because of kinking of the fallopian tubes. Thus, endometriosis causing intrapelvic adhesions or PID causing intrapelvic adhesions will lead to ectopic pregnancy. Infertility treatment, ovulation induction or IVF. In IVF, we transfer embryos directly to the fallopian tube or to the intrauterine cavity and that may increase the chances of ectopic. Even ovulation induction process increases chances. Previous ectopic pregnancy. This is a very important factor. So if a patient has previous history of ectopic pregnancy, she has 10 to 15% chance of repeat ectopic pregnancy in the next pregnancy. Previous induced abortion. Again, you all understand that induced abortions can have few infections ascending, reaching to the tube, causing damage, thus leading to ectopic. Developmental defects. If there are pocket formation or diverticulum formed in the fallopian tube, it will also lead to ectopic. Endometriosis, presence of fibroid in the uterus, transperitoneal migration of the sperm means the sperm goes inside the uterine cavity, goes to the fallopian tube, comes out and then gets migrated to the other fallopian tube through the fimbria because both the tubes are lying in the pouch of Douglas close to each other and thus causing implantation there may it increase the chance of ectopic pregnancy. Now let's see what are the types of ectopic pregnancy. Acute means ruptured ectopic. Ectopic in the fallopian tube or anywhere and the organ has ruptured. So you all imagine that this is an obstetric emergency. This is that adrenal rush phenomena where patient can be in shock. We have to deal with such a situation urgently and we as an obstetrician or as a doctor should always be ectopic conscious. Any patient having amenorrhea with symptoms of acute ectopic can land up in shock and thus can die with this condition if it goes unrecognized. So we have to be always ectopic conscious. We should think of ectopic, rule out ectopic and then think of other differentials. Other type is unruptured where the patient will not be in shock. Ectopic is there but it is unruptured, it's not causing intraperitoneal bleeding. And third one is chronic variety where either the ectopic has ruptured but the bleeding has got stopped because that rent got sealed or the ectopic has got aborted from the fimbrial end and with some bleeding it has landed in the pouch of Douglas and now a pelvic hematocele is formed. So again this patient would be chronically ill but it will not be an obstetric emergency. So these three types which we see in ectopic, let's see how to diagnose them and how to treat them. As I said, acute, ruptured or disturbed, they are one and the same. It's seen in 30%, it's associated with tubal rupture or maybe tubal abortion through the femoral end, but it can be associated with massive intraperitoneal hemorrhage. How is the clinical scenario? Usually young patient in the reproductive age group around 20 to 30 years, mostly nulliparous. Maybe history of infertility treatment. She comes with acute symptoms. The onset is very acute. There is a typical triad of symptoms. Amenorrhea, maybe of short duration, maybe that she's around 6 to 8 weeks, or sometimes just a delayed menses, that she says my menses got delayed by 2 days or 3 days. Or maybe sometimes there will not be any history of amenorrhea. She's due, like tomorrow is her date, expected date. She comes with this variable period of amenorrhea. First symptom. Second, abdominal pain. Most constant feature of ectopic pregnancy is abdominal pain. And third, vaginal bleeding. So this is an important triad for symptoms of ectopic pregnancy. Pain would be agonizing, colicky, and typically in between the colic, patient will remain in agony. She will not be relaxed. So amenorrhea, abdominal pain and vaginal bleeding. Now why there is pain? This pain is because of wherever that ectopic is located, that is distending that site. So distension of the tube, the peritoneum is getting stretched, that is leading to pain. Colic of tubal muscle, peritoneal irritation and hemoperitoneum. All these factors, they contribute to this pain which is there in ectopic pregnancy. Hemoperitoneum, because of peritoneal irritation, can also lead to shoulder pain or epigastric pain along with abdominal pain. Vaginal bleeding, that is the third symptom of the triad, can be slight, sanguinous or dark in color. Along with these three symptoms, there can be nausea, vomiting as an early symptom of beta-hCG secretion because of the pregnancy. There can be fainting attacks or there can be syncope in 10% of the patient. Because of this peritoneal thing, patient just gives history that she had a fall, she had a syncope. So these symptoms, this is the presentation of a ruptured ectopic pregnancy. If these symptoms are seen, you have to think of ectopic pregnancy that also ruptured. Do a quick pregnancy test. If it comes positive, do the further investigations. If you suspect ectopic, you have to immediately act, revive the patient and stop the bleeding as early as possible. On examination, the patient would have tachycardia. She may be in hypotension or in shock. She would be pale because she is losing blood in her abdominal cavity. The pallor will depend on how much blood she has lost. Per abdomen, there would be tenderness, muscle guard on the lower abdomen on the affected side. On PV examination, you will feel irregular or tender mass. Cullen sign is dark bluish discoloration around the umbilicus, which suggests intraperitoneal hemorrhage. So this sign, please remember. On PV examination, vaginal mucosa would be pale, uterus would be normal or just bulky, it would be soft, cervical movement would be tender. This is classical of ectopic and PID. That cervix, if you move on by manual examination, there would be tenderness. The fornices on either of the fornix where the mass is, where the ectopic is, there would be a palpable mass and they would be tender on examination. Or if it's ruptured, you will feel a ill-defined, boggy and tender mass through the posterolateral fornix extended to the pouch of Douglas. This is typical of chronic ectopic because now that ectopic has either ruptured, aborted, some hemorrhage, gone in the pouch of Douglas and settled there. And this is a pelvic hematocele which we are feeling on the examination. In acute, you will have feeling of cervical movement tenderness, pale vagina, fornix, some mass, tender, and if there is intraperitoneal bleeding, you will have a sensation that the uterus is floating. This is called floating uterus sign, where in the intraperitoneal fluid, or that means the blood, the uterus is kind of floating. You have to immediately think and diagnose it as ectopic. How unruptured ectopic will present? The symptoms will not be that shocking. Usually she'll give history of delayed period, maybe some spotting, uneasiness on one side or on the flank, and continuous colic in nature, the pain would be there. Signs: the uterus is slightly smaller than the period of amenorrhea because it's not growing inside the uterus. A small pulsatile, tender, well circumscribed mass will be felt in one fornix, which is separate from the uterus. So this is a pregnancy which is growing in some other site than the uterus, but yet the site is not ruptured. In chronic ectopic, the symptoms would be there would be amenorrhea of 6 to 8 weeks. There is lower abdominal pain which started as acute, but gradually over a period of time it has become dull and colicky. There may be some vaginal bleeding from the uterine cavity. Other symptoms: because of this mass which is there in the pelvic cavity, there can be bladder irritation, dysuria, frequency or retention of urine, or there can be rectal tenesmus because of infected pelvic hematocele. On examination, these patients look ill. She will not have, the patient has ill looking face, varying degrees of pallor depending on howsoever amount of blood she has lost in the uterine in the peritoneal cavity. Persistent high pulse rate. Even at rest, she would have tachycardia. Features of shock will not be there, but ill looking patient with tachycardia and some rise in her body temperature would tell us that maybe she is having chronic ectopic. Now, how to confirm our diagnosis? We have investigations which should be done not for diagnosis but for evaluating her general condition in case, usually as mainly in acute, that blood examination we should know her hemoglobin percentage and blood grouping and RH typing because we need to transfuse her and treat her shock. Then we have investigation like beta-hCG, quick urine pregnancy test. You have a patient with these symptoms, urine pregnancy test come positive, you do ultrasound which shows no gestational sac in the uterus and you say that this is ectopic. In chronic or unruptured, we can have beta-hCG levels, serum beta-hCG level. The concentration would be lower, means if the pregnancy is of 5 weeks or 6 weeks and if it is in the uterine cavity, naturally beta-hCG levels would be high. But if it is ectopic pregnancy, for those weeks of gestation, the beta-hCG levels are lower. And if you see the doubling time, means today I have done beta-hCG and I have repeated the levels after 48 hours, there will not be doubling. Doubling time in plasma will fail. The rise in beta-hCG would be less than 66%. Ideally, it should double in 48 hours if the pregnancy is growing in uterine cavity, but it will not happen. The next investigation which will help us is sonography. In comparison with transabdominal, transvaginal is much more sensitive to diagnose ectopic pregnancy. The first sign would be absence of intrauterine gestational sac with positive pregnancy test. Pregnancy test positive but no sac in the uterine cavity. If there is presence of fluid in pouch of Douglas, then it is clear-cut indication that we are dealing with this acute ruptured ectopic and we have to act fast. In case of unruptured, we will see a adnexal mass separate from the ovary. Now we can see a gestational sac, there may be a fetal pole or a yolk sac. Sometimes even cardiac activity can be seen in the adnexa wherever that pregnancy is growing. Usually, there would be this hyperechoic ring or tubal ring seen around the gestational sac. This is Bagill's sign or tubal ring sign. If you put color, that means you use Doppler. Usually in intrauterine pregnancy, you see ring of fire. That means the vascularity of pregnancy will give appearance of a ring. Now this ring you are seeing extrauterine. This ring of fire on Doppler examination seen outside the uterus is again a good sign, a good test to confirm that we are dealing with ectopic pregnancy. TVS along with beta-hCG increases the sensitivity. We can confirm the diagnosis or by using these two tools together. But laparoscopy is the gold standard for diagnosing ectopic. You are putting in a scope, you are seeing that yes, the pregnancy is at tube or ovary or extraperitoneal or intraperitoneal, you are directly visualizing it. So the gold standard for diagnosis of ectopic is laparoscopy. To complete the list, we have other investigations, but these are not done routinely in clinical practice. Like you do dilatation and curettage, and you send the endometrium for presence of chorionic villi. If the villi are absent, that suggests the pregnancy is somewhere outside the uterine cavity. You can just do a flotation test on it. Serum progesterone levels. In a normally growing pregnancy in uterine cavity, serum progesterone levels would be more than 20 nanograms. But if the levels are less than 5, they suggest that pregnancy is not in proper place. In case of fluid in pouch of Douglas, if you just put a needle, that is called as culdocentesis. You are putting a needle in the pouch of Douglas posteriorly and you aspirate blood which you keep in a test tube and it doesn't clot. It suggests intraperitoneal hemorrhage and it confirms that you have ruptured acute ectopic. And again, we can also have laparotomy as a tool which will diagnose as well as therapeutically treat the patient. Now, how to manage ectopic pregnancy? Again, depending on the type of ectopic pregnancy, the management varies. This is dramatic presentation. Treatment is also dramatic. We have to act fast. Resuscitate the patient depending on her clinical condition. Both the things are simultaneous. It's not that we have to do one thing and then gradually do the other thing. She is bleeding inside. The tube or whatever is the site of the tube ectopic has ruptured, and from that ruptured site she is bleeding continuously. She is pouring blood in the peritoneal cavity. So you have to simultaneously resuscitate her to maintain her blood volume, and at the same time you have to take steps to stop this bleeding. So resuscitation and laparotomy simultaneously. So we will put intravenous cannula, large bore, push IV fluids, send her blood for hemogram, RH typing, grouping, cross-matching. Someone will rush to get blood from the blood bank. At the same time, you are informing OT, getting the OT ready for operating on her. So you are making the patient hemodynamically stable. At the same time, you are preparing for the surgery and shifting the patient for surgery in the OT. Principle for laparotomy: quick in and quick out. You have to go in quick, stop the site of bleeding, because till you stop, whatsoever blood you are giving intravenously, it's not going to work because it's coming out from the other side. So quick in and quick out are the principle of the surgery in acute ruptured ectopic pregnancy. In a patient who is hemodynamically unstable, laparoscopy is contraindicated because it takes time. So laparotomy would be quick and much helpful to the patient. If there is evidence of rupture, laparoscopy is contraindicated. But now as the science is getting advanced and people are having mastery on the laparoscopy, people are going for laparoscopic management even in case of ruptured pregnancy in hemodynamically stable patient. What do we do? Either laparoscopically or laparotomically. We go inside, we look at the site where the rupture has taken place, we clamp it and remove that much portion of the tube, that is called as salpingectomy. This is definitive treatment, removing that portion, salpingectomy. If it is an ovarian pregnancy, if we can repair the damage of the ovary, we will do that. But if we cannot, then oophorectomy is done. That much portion of the ovary or that ovary is removed. If it is an interstitial pregnancy, we cannot spare, so subtotal hysterectomy is done and the bleeding is stopped. So remember, in acute pregnancy, both the things, resuscitation as well as stopping the bleeding and the surgery required for that, both are simultaneous and they have to be done in an emergency. We are not supposed to waste any time. Dramatic presentation, immediate diagnosis and immediate treatment are the basis for treatment of acute ruptured ectopic pregnancy. In case of chronic ectopic, it's not an emergency. So we can deal with the patient with some time. We can confirm the diagnosis with the help of beta HCG levels, with the help of progesterone levels, ultrasound, and wherever we confirm, then we can plan a laparotomy. A pelvic hematocele would be found. Those blood clots we remove, and then we remove the salpingectomy can be done depending on which portion is affected.